next speaker is Dr. Bibhuti P. Kashyap, and he has done his senior residency, post-graduation and senior residency from RP Center AIMS in Vitreretna, and currently he's a deputy director and head of Kashyap Memorial Eye Hospital in Ranchi, and he'll be telling us about the approach that should be followed in cases with post-closed globe injury vitreous hemorrhage, including submacular hemorrhage. Over to you, Doctor.
Good morning, everyone, and thank you, Dr. Devesh, for making me a part of this IC. So my topic for today is post-traumatic vitreous hemorrhage with submacular bleed. So amongst the many causes of vitreous hemorrhage, the cause that we have to look for in a post-traumatic vitreous hemorrhage is usually a PVD with retinal tear, a PVD without a retinal tear due to the pull on the normal vessel, and a blunt trauma causing a retinal break, choroidal tear, optic nerve avulsion, retinitis proliferans, and penetrating trauma. The mechanism of vitreous hemorrhage in a case of trauma would be disruption of a normal retinal vessel due to those causes that I mentioned before. So the workup would involve evaluation of the eye vis-a-vis cornea for edema and opacities, AC for cells flare, foreign bodies, RBCs, iris for synechia, tears, holes, sectoral atrophy, gonioscopy for angle recession, foreign body, RAPD, lenticular changes, glaucoma, retinal detachments, ultrasound to look for location, density, and nature of vitreous hemorrhage, any vitreous attachments, presence of tears, presence of RD, foreign body, OCT when the media is clearer to look for macula status, and X-ray, CT, or MRI, preferably CT, to evaluate presence of intraocular foreign bodies. Now, grossly, what we have to see is if the cause of vitreous hemorrhage is determined if the retina is adequately visualized, and if yes, then we have to treat the cause of the hemorrhage. In trauma cases, it's usually a break, so you laser or cryo those breaks. If the media is not clear, we have to usually see if the vitreous hemorrhage can be safely observed, which usually is not the case with a traumatic case, which mostly needs a prompt vitrectomy. My focus on our vitreous hemorrhage is a Pandora's box, because when we enter inside, we may find anything, right from what has already been discussed to what will be discussed later in this IC. My focus will be on submacular bleed. Submacular bleed is a sight-threatening condition that needs prompt attention, and the most commonly used treatment for this modality is problem is pneumatic displacement. It is usually combined with a tissue plasminogen activator, the dosage of which is 100 micrograms per 0.1 ml with a 0.3 ml of 100% C3F8 gas. Now, what is the rationale behind this? If you look at this diagram carefully, what we see is that the submacular bleed needs to be displaced from the macula, and when the bleed happens, the buoyancy force and the gravity force usually cancel each other out. So when we replace the vitreous cavity with the gas is there at the interface of the bleed. So the displacement, the buoyancy caused by the displacement of the gas is lesser than the gravitational pull of the submacular bleed, and that is how it settles down. In a case of a vitrectomized eye, we may not use a proper positioning, but in a case of a non-vitrectomized eye, such as in a non-surgical management, when the gas fill is not completely covering the entire vitreous cavity, the positioning needs to be given such that the gas comes at the surface of the bleed. Thereby, the buoyancy that is faced by the bleed clot is due to the displacement of the gas and not the vitreous humor. Now, the prerequisite for this is a non-adherent and mobile liquefied clot, which is where the tissue plasminogen activator comes into play. It causes the clot to get mobile by liquefaction. There is adhesion prevention, and the liquefied blood has a slightly greater density than that of an intraocular fluid, so the blood tends to settle down. Now, this is my case, which has an ambiguous case history. It is a case of PCV, which presented with diminution of vision for 13 days post an accidental blunt trauma, and the patient showed a presence of massive submacular bleed. The OCT had a picture like this, and my plan was intravitreal TPA with anti-VEGF with a C3F8 gas. and post the first dose, there was marked reduction in the submacular bleed, and post third dose, there was complete resolution of bleed and complete inactivity of the PCV2. And this was the post procedure at 3 months. The fundus photograph looked like this. Now, this is a simpler method, a non-surgical simpler method of treating a submacular bleed, but the outcome is unpredictable due to multifactorial causes, some of which being the non-penetrability of TPA to the subretinal space, which is where the surgical management of PPV with subretinal TPA comes into play, the dose of which is 25 to 30 micrograms per 0.1 ml. So apart from the obvious rationale of it bypassing the retinal barrier and acting on the clot directly, what it also actually does secondarily is mechanical displacement of heme away from the fovea because of the inflowing gush of the TPA fluid within the subretinal drug bubble. The concern is a controlled subretinal microdose delivery, and which is where most of the perception of it having a steep learning curve comes into play. So the entire need is to obviate this steep learning curve, and which is why I use a microdose injector with a 38 gauge needle. You fit this to a silicone oil plunger, and you shift the control of the drug delivery from a manual handheld control to an automated foot pedal control, which even with full throttle gives a very, very slow delivery, which is evident by the video here. The rate of wetting of the towel is how slow the drug goes, even with the full throttle of the Constellation foot pedal, and you can get a very controlled formation of subretinal bubble. And this is a case demonstrating the same. I don't have the audio for this. Yeah, so after a core and a peripheral vitrectomy, all you have to do is, and this is a 360 degree laser barrage being done, and then you just pierce the macula with the 38 gauge, you press the foot pedal completely, and you have a very slow and beautiful formation of a subretinal bubble, and that is it to it. Followed by fluid air exchange, and there is no learning curve to this. Third week post-op, there was complete resolution of the submacular bleed, and the pre-op OCT, which looks something like this with a BCV of finger counting close to face, improved to a post-op 5/60. My case 3 is that of a post-traumatic retinal detachment with a submacular bleed. In this case, after placing a segmental 276 tire, went for a PPV for the RD. But after the core and a peripheral, I went in again with the same procedure. You can see the intraoperative dissolution of the clot and displacement, and its displacement away from the fovea, and later on you will see the collection of the liquefied blood inferiorly. There you see the clot getting away and dissoluting. Followed by a fax, and you can see the collection of the liquefied bleed inferiorly to the macula. And of course followed by laser and oil injection. Now 6 weeks post-op, BCVA improved to a 3/60, and post-SOR follow-up, the BCVA was 6/60 with 20 millimeters of mercury IOP, control on brimonidine and timolol. Some other case examples include a post-RTA submacular bleed. Here you can see a relatively high submacular bleed, which some surgeons also prompt to go ahead with probably a retinotomy, a large iatrogenic tear formation with a diathermy, even for bleeds larger than this. But in this case also, what I did was create a small retinotomy just inferior to the macula, and inject the TPA, the so-called subretinal TPA lavage. The blood liquefies and evacuates through that small hole, so it obviates the need of creation of a large opening. Subsequently, lesser amount of PVR formation and no use of oil. In this case, I evacuated with the help of a gas tamponade, and vision improved satisfactorily to a BCV of 6/36 with complete restoration of anatomical normalcy. This was a case of a post-traumatic subpapillomacular bundle bleed. Now, most of the surgeons, they are I have seen that they have been apprehensive about the use of submacular TPA, and there have been indications, they have been quoting literature saying this is not the amount of bleed that needs a TPA, it can go with a pneumatic. Every explanation regarding this stems from the apprehension due to a steep learning curve, but when you remove that steep curve of the manual control, you can reduce a threshold, and that reduction is sometimes useful, because in this case the bleed is very small and very less, but it covers the most important area of the macula, the papillomacular bundle. The height even is not much, but in this case also I went in for a surgery with a subretinal injection of TPA, and the vision at 1 month improved to a 624 parts with complete restoration of the anatomical normalcy. My final example is that of a new on old submacular bleed. This was a case of post-traumatic submacular bleed because of a choroidal rupture, which did not resolve completely and formed a secondary CNVM, which again bled. And this also was done with a subretinal TPA method. In this case, I would like to highlight the importance of the secondary mechanism of the TPA use, in which it mechanically also displaces the bleed and the clots from the macula due to the gush of the fluid inside the subretinal TPA bubble. And at 1 month, the post-op BCVA improved to a satisfactory 5/60 with as much as possible restoration of the anatomical normalcy on OCT. Thank you.
Thank you, Dr. Bibhuti, for the wonderful videos that you have shown, managing different types of patients with different approaches, including pneumatic displacement alone as well as subretinal injection of TPA. So I have a doubt that what is the drug volume that you inject in such cases? Is it always fixed, or you modify as per the size of or the volume of the subretinal bleed?
So in cases where I'm not doing an evacuation through a retinotomy, I would fix it to a 0.1 ml or a 0.1 to a 0.15, not more than that. And the concentration of the drug should be 25 to 30 micrograms. You may increase it up to 50 micrograms, but not beyond that, because drug toxicities have been reported. Toxicities have also been anecdotally reported at dosages as low as 25 micrograms, but in my cases, I have not experienced any atrophic patches or any loss of vision. Some people have said that there is observation of retinal whitening with a subretinal injection, but even that is transient. Happens in some of the cases where you don't have a spacious bubble that you have formed. In that case, there is retinal edema which resolves when you have a gas tamponade and you see the patient 1 or 2 weeks later.
I think that whitening can also occur if you are in the intraretinal area space rather than in the subretinal space.
Not so much. Most common cause of that is an inadequate sizing of the bubble, which may cause an increased pressure causing a retinal edema.
Thank you, Dr. Bibhuti.
And do you think the presence of a choroidal rupture alters your decision making in the case as to the site of injection or the counseling of the patient, or do you want to do the procedure or not? If you see a choroidal rupture passing through the posterior pole.
Yeah, I would usually go for, usually when you have a submacular bleed, what I have seen is once the bleed clears off, you usually have a choroidal rupture. So whenever I see a posterior pole bleed, I always counsel the patient for a surgery regardless, because what I see later on doesn't affect the decision. All the possibility of what I'll see later on will not affect my decision of treating the submacular bleeds in this case. I mean, with this method.
Thank you.